So please be ready.
Good afternoon all.
Start.
Thank you for your time. I'll be talking about comparison of two techniques from the surgeon's perspective and refractive outcomes. There are no financial discourses and all consents were taken appropriately. So why this study? The most dreaded complication of a pediatric cataract surgery is visual axis opacification, as a recurrent VAO can lead to intractable amblyopia in the child. With a longer life expectancy, we do expect LECs to grow and cover the visual axis. So a standard in the bag IOL implantation, although has an initial barrier effect, it also has a delayed secondary barrier failure due to sommerings. But a posterior optic capture of a multi-piece IOL through the PPCC with anterior vitrectomy does not allow these LECs to grow out of the capsule complex, and it is limited to the sandwiched capsules. But can this be done easily in all cases? That was our main concern. So we evaluated the intraoperative challenges and the post-operative outcomes of these two techniques. We did an ongoing prospective longitudinal interventional study from September 21 for bilateral congenital cataracts. We included all the children which were diagnosed with bilateral developmental cataracts between the ages of 2 to 8 years, and both eyes were operated within an interval of 2 weeks. Follow-up was done up till 24 months. So what we did was to remove the confounding factors of propensity of patients to develop VAO. We implanted in the bag IOL in one eye, the first eye, and the group 2 was second eye, in which we did a optic capture of a multi-piece IOL. This was a surgical technique. Gimbel has described 5 various techniques of optic capture in pediatric cataracts. What we used was we placed a sulcus IOL, and then we dialed the sulcus IOL we placed the sulcus multi-piece IOL, and then we captured the optic behind the capsule. As you can see here, behind the posterior capsule, we have captured the optic through the PPCC. Carefully using 2 dialers, as you can see here. This is the optic capture being done behind the posterior capsule. So here you can see the outlines. This is your posterior capsule outline, and this is your anterior capsule outline, and they are forming a sandwich in front of the IOL while the haptics remain in the sulcus. Total sample size was 21 kids between with mean age of 5.3 years and mean follow-up of 14.75 months. There was no gender preponderance. There were 3 dropouts. One was due to deep AC in high myopia, which the surgeon was uncomfortable to do a posterior optic capture. One case had a pre-existing PC dehiscence, so we did not take up for optic capture, and one case was lost to follow-up. So intraoperative outcomes, the main was time taken for technique. In the bag IOL had a moderate time for 54 to 80 seconds, which remained stable throughout the study. But posterior optic capture, which initially took a lot of time, and later as the surgeon got used to the technique, it reduced. But still it was significantly higher than in the bag IOL. Intraoperative outcomes there were various challenges faced by the surgeon. There was one single surgeon with experience of approximately 8 to 10 years in pediatric cataracts, and we have taken her feedback. Then coming over to refractive outcomes. So initially there was high cylinder in all the cases because of the suture that we put in pediatric cases, but as you can see, the refractive error stabilized after 6 months, and there was no significant difference between the two groups. There was visual axis opacification in 5 in the bag IOL cases and 4 in the posterior optic capture cases. Anterior capsular phimosis was found in 2 cases of group 1 and 2 cases of group 2. So there was basically no significant difference between the two groups in terms of implant status. Coming over to the strength of this study, we had a larger sample size as compared to other studies which have been done previously using these two techniques. And we took a subjective surgeon's feedback, because a technique is as good as the surgeon who does it. Limitations were we had only one single operating surgeon who was doing the study, and we need a longer follow-up for visual axis opacification score. But in terms of implant stability and visual axis opacification, there was no significant difference in the fibrinous complications between the two study groups at a mean follow-up of 14.7 months, as compared to Savleen Kaur's study, which also showed similar outcomes. Then another study which compared two techniques in a similar pattern of implanting IOLs in the 2 eyes of the same patient. We had similar outcomes, but our surgeon found the technique of posterior optic capture more difficult and time-taking. Another study which shows the refractive status outcomes, we had better outcomes and no significant difference between the two groups. They also showed no significant difference between the two groups. But we also had the same amount of myopic shift in our patients at the end of their follow-up of 24 months. Conclusion: in the bag IOL is a preferred technique of choice because it is easy to do, and posterior optic capture with haptics in sulcus, there are a lot of cons and can be done only in hands of experienced surgeons. Thank you. Thank you so much.
What was your follow-up, Ma? How much?
Mean was 14.7 months. The latest case which we did was a 6-week follow-up, and the oldest one was 24 months follow-up. We are still following up the cases.
I suppose you need a longer follow-up to really come to a conclusion,
Yes,
which would be better, right?
Yes,
because it's a pediatric eye.
Yes, ma'am. So here in this study, our main concern was the challenges faced during the procedure. Can it be done by everyone? Because at a later stage, it is difficult to exchange a in the bag IOL. It is easier to exchange a IOL whose haptics are in the sulcus. And IOL exchange is increasing in demand with our pediatric cataract cases as they grow up.
Yeah, for the better refractive outcomes.
Yes. Thank you.